problems and to find out what makes someone vulnerable to having particular issues. So we don't just find out and say, well, someone is depressed, and we treat the depression. We try to understand what makes this person vulnerable to having depression. So if 4 of you were in a family and you had depression, my question would be, what makes you vulnerable to have depression and you don't have it? And I guess there's a curiosity that guides assessments. We do observations, we might use psychometrics to try and understand particular processes, and put together, that forms your assessment within a medical setting. We also do what is called formulation, which is, I guess, is in line with perhaps what people see as a diagnosis. And this is a skill that is, I guess, quite unique to clinical psychologists, but other professionals may also use formulation. So within physical health, I would be interested in what are someone's life experiences? Why are they vulnerable to not coping well with their diabetes or their chronic pain? What coping resources do they have? So has this person had a history of not coping very well? If they haven't, then we know that they're not going to cope well with any of these as well. If they've coped well with problems before in their life, that is a good strength to have, because it means that they'll be able to adjust much more better. What incidents or critical incidents have occurred, and what is the personal meaning of having any of these conditions? Okay, so for this person on the left, she has been diagnosed with type 1 diabetes. That has then triggered a thought such as, why me? I can't cope. And then she panics, and then she has more memories of her mum having diabetes and having her leg amputated because her mum didn't manage her diabetes. For this person here, they have the thought that I'm useless, I can't do the things I used to do because I have chronic pain, and so they become depressed, and as a result of that, they don't ask for help when they need it. So the cycle can continue. But formulation helps us to understand what is the personal meaning of all of this, and how can we understand this person's difficulties. Okay. In terms of treatment, it really depends on the presenting issues. So if someone's anxious, if they're not coping, if they're not adjusting to their operation or their medical conditions, etc., that will determine what talking therapy that we offer them. Yeah. Sometimes we might devise interventions alongside other professionals, so we might share that ownership in terms of helping someone to overcome their conditions. And very much so in physical health, you're often not working in isolation. It's important that we draw on the skills of other professionals. So getting people like the nurses or the doctors or the physiotherapists on board with us, because people are likely to, these patients are likely to still have input with all these other professionals. Okay. So these are our objectives. This is what we hope to gain from having psychology in medical settings. So we hope to improve adherence to treatments. We hope to improve the likelihood of people sticking to their treatment and having a better quality of life. We hope to promote better coping behaviours. We hope that people are coping better with their conditions. We hope to improve their family function, because if somebody is distressed because of their physical health condition, of course it's going to have an impact on their spouses or their family members. So we hope to then improve communication and better functioning within your family system. We also want to provide support for distress related to illness, so breaking down the stigma surrounding going to see a psychologist. Sometimes patients can be their own psychologist without having to make the step to see us. To evaluate and treat psychopathology, so things like depression or anxiety, that's what we hope to gain. But in some cases, medication might be needed for some individuals, and that is okay. And we might often refer them to psychiatry or to the idea of having a chronic condition, because it can have an impact on your emotional well-being. It can have an impact on the way that you view yourself and your situation. So it affects your thoughts, it affects your feelings, and of course it's going to affect what you do. And I guess chronic pain, we'll look at that in a few slides on. Working in physical health or within medical settings, often when patients are referred to us for psychological assessment, most of them don't really know why they're there, because they can't quite link between, I've got a physical condition, so why am I seeing a psychologist? So this person might think, well, why do I need to see a psychologist when I have a pain problem? They can't quite get the connection between the two, or I'm not quite sure why I'm here, I only came because my doctor asked me to. So the doctor recognizes that these individuals might have psychological issues because they're not managing their condition. but they might not see it that way because they haven't quite understood the link between disease or body and mind. Does that make sense? So a lot of people will actually struggle, on their own, not really seeking help for their problems because they feel that they shouldn't really be feeling depressed or feeling anxious. But according to Albert Ellis, the best years of your life are the ones in which you decide your problems are your own. So it emphasizes taking control of your problems and seeking help and problem solving. So let's look at chronic pain then, to demonstrate the link between that and psychology. Now, most people with chronic pain have a medical knowledge of what pain is. We've all experienced pain to various degrees, whether it's been toothache, backache, pain in your, from a sports injury, etc. So all of us have some knowledge of pain, so most patients would have some knowledge of pain. And a lot of us might think, well, because I feel pain, that might equal some damage of some sort. But sadly, that's not the case for patients with chronic pain, because a lot of them don't really have a formal diagnosis. It's just classed as almost like wear and tear. So of course, that's not going to be satisfactory for people who are living with chronic pain. And because you feel pain, you might have the expectation that your pain can be eliminated through medication, through operations, etc., etc. But obviously, for a lot of chronic pain patients, that's not the case. And so their distress might be influenced by lots of success stories of new treatments that might not necessarily work. Also, the fact that media might also advertise new treatments for pain, but when you try them, they don't work as well. And while all that is going on, this individual has to carry on with life regardless of all of that. So that can be a particular problem for a patient. So what are the psychological factors in chronic pain then? Well, anxiety is quite common because it might present as feeling quite nervous, feeling quite tense or restless, but it might be more connected to the meaning of the illness. So people don't just become anxious because they have pain. It has a lot to do with the meaning of the illness. So if I have chronic back pain, I might become anxious because I can't do my job as a psychologist. And I'm worried that people might not think I'm pulling my weight. So the thought process there, because the meaning of it is that I'm probably too young to have back pain. It affects much older people. So meaning is quite important in physical health, because that can have an impact on how you respond to your treatment. If you feel that you shouldn't really be feeling like this, that can have an impact on how you respond to your treatment and the sort of help that you receive. The anxiety might be connected to having a lack of a formal diagnosis, because the doctors might tell you, well, you've just got wear and tear. So for a lot of people, they actually want more than that. They want to know more about, why am I experiencing this pain given I had an accident? Surely there should be something you can do, like increase my medication so that my pain is reduced and my distress goes away. The lack of prognosis as well, because people want to know, how long am I going to live with this chronic pain? Is it going to go away tomorrow? I've been living with it for 4 years now and nothing has helped. And now you're referring me to a psychologist. Well, you must think I'm imagining it. And anxiety can lead to a reduced personal competence, so not feeling confident in being able to manage your life or the responsibilities that you have. And because of that, you might start then coping not coping in a way that you used to do before. And of course, most people, if you were previously very independent as an individual, then you have something like chronic pain, which means that you're much more dependent on others, then this independent person is actually going to struggle to deal with being more dependent on people. Make sense? Yeah. Depression is quite common with most, I guess, medical conditions, and it could be the factor that influences whether people engage in treatment or not. And it can present as low mood, having negative beliefs about yourself, about others and the world. It can lead to a sense of hopelessness, as Pooja identified earlier on, pessimism, etc. But again, it all goes back to the personal meaning of having a chronic condition. So in this case, someone might become depressed, not because they've got chronic pain, but because of the personal meaning of having chronic pain. So because they are very much focused on their previous life prior to having pain and comparing it to their current life where they see themselves as quite disabled. So grief over your previous healthy life can lead to depression because you can't quite accept your current situation. And that can be a problem. Like, if you don't ask the right questions, you will never know this. You might just think, well, this person is depressed because of their pain. But meaning is quite important within physical health. And depression is one of the most common psychological forms of disturbance in most medical patients. Now, there are lots of individuals who already have a history of depression and anxiety who then develop a physical health condition. Now, these individuals will actually struggle with a new diagnosis because they don't have the resources to deal with this new condition. There are some people who have no history of depression or anxiety, but they develop chronic pain and become depressed. But this group of people already have it, they have depression or anxiety, and then have a physical condition. And that just complicates matters further because they don't have the resources to deal with all of that, both your mental health condition, but also physical condition as well. Any questions so far? Going at the right pace? I can get a bit of enthusiastic, so we'll keep going. Anger is quite common in chronic pain because often people identify any of these as the causes of their pain. So either you've been involved in a car accident and it's contributed to you feeling some form of pain, or maybe you slipped in your job and so you see the cause of it to be your employer, or the fact that you've had several operations and the pain hasn't gone away, so it might be something to do with the doctors or the therapist, or the fact that there's an ongoing legal process associated with having an accident and it's because of them I'm still in pain. Injustice because you've lost your job, maybe financial hardship. So all these are sort of things that people might focus on as a source of their anger. Okay. So I'd just like to clear away some misconceptions about the emotional reactions for people with pain. Because a lot of people do have chronic pain and their pain is real, even though we can't see chronic pain. The fact that people verbalize a sense of anxiety or depression or irritability, it is real. But then they don't have a personality disorder, they don't tend to have a psychiatric illness, and they're not malingering, so they're not complaining that they have anxiety or they're in more pain because they want to receive some sort of finances for them. So I guess we have to see all people to view their pain as being real. Okay. And so far I've highlighted that there's an emotional side to living with chronic pain. It can affect what you do as a result of that. If you're depressed, you might not want to try anything else. It may mean that you present at doctors' clinics all the time looking for a cure. It could affect the way you view your condition. So there's a lot of links between the emotional, the thought process, and the behavioral factors as well. Okay. So most people with chronic pain are not psychologically different from the rest of us. They're just reacting to their situation in a normal way. So if we were in that situation and faced with a major change in our life, of course all of us would react in that way by complaining of being in so much pain or being fearful of increasing our activity levels because we think that it's going to make your pain worse. In actual fact, activity actually helps you to manage your pain. So much of their distress can be understood as a result of their symptoms or their disability. So in other words, they're normal people reacting to an abnormal situation. And the meaning of their symptoms is quite key, as I've stressed before. So or it could be a way of reacting against the way that they've been treated, because a lot of doctors might feel that they are imagining it. So I'll just refer you to the psychologist. They'll deal with you and assess you and then find out what the real issue is. But for a lot of people, that's just the way life is. I mean, I know what it's like to live with toothache. Imagine having that pain every single day. Of course, it will have an impact on how you feel. You won't be as cheerful. And you might not be very motivated to do the things that you enjoy. So it's bound to have a significant impact on what you do. So here are some common beliefs about chronic pain that patients might hold in terms of their belief that it's due to serious disease which has been overlooked. And in most cases, it's not due to serious disease. And most people have had lots of scans, and all it shows is that it's just wear and tear or something else, or that it's due to serious irreversible damage, or people will think that it means I'm vulnerable and I'm going to have further injury. Because I feel pain, that means it might get worse. I'll eventually end up in a wheelchair because of my pain. I'm going to become disabled. So these are all lots of ruminations that people might have because of their pain. Or that healthcare professionals do not believe that I'm in pain, and that's the reason why I keep moving from one doctor to another. Now, I learned a lot from my experience of working in pain clinics in the UK as a psychologist. We had a really good doctor there. He was very psychologically minded, and he was basically saying a lot of doctors don't feel that they can tell the patient that there's nothing more I can do for you, but instead what they will do is then ask the patient to go for another scan, and all that is maintaining the problem, which could be stopped earlier on by saying there's nothing more I can do for you rather than medication, and your pain might still continue. So it's quite hard for other people to communicate that to patients, and that might maintain the problem. So what is the role of clinical psychology then within chronic pain? Well, I think there's a major role to help patients to manage their emotional reactions, to normalize their reactions. Yes, we believe that you're in pain, and if anyone else was in that situation, of course, you would be feeling quite anxious or depressed. A lot of people might adopt a sick role, so they have actually gained quite a lot out of being in medical services, because it means that they are cared for by professionals, which they might not get in their personal life. Having chronic pain has the potential to generate grief and loss issues, because you're constantly comparing your current situation to what your life used to be like before, which I guess is quite normal, but it's a wrong comparison to make and quite unhelpful, which might then maintain depression. You know, making statements such as, well, life is so awful at the moment because I now have chronic pain, and I used to be able to do football or to, run with my kids in the park, but now I can't do that because of my pain. So statements like that are likely to make people feel much more depressed. The personal meaning, as we've seen, is very important in physical health conditions. It's not just having cancer, HIV, or pain that's the issue. It's about what it means to be an individual rather than the condition itself. Psychologists can help people cope with change, so changing their lifestyle, which might go along with working with the grief issue, because in order to move to acceptance, you've got to go through the grief process, and that doesn't mean ignoring all the awfulness about having chronic pain. It's about supporting somebody dealing with all the grief in order to get to acceptance. And acceptance links in with psychological adjustment, because we all have to adjust to new situations. It's seen as a process that we go through life, where we incorporate this perceived physical disability into our current life view. Symptom management, because if you're feeling quite anxious, it's a normal reaction, but it can get out of control. So clinical psychologists have a role in terms of helping services to understand why people are reacting in a certain way, and also by educating patients to manage their symptoms a bit better. Now, in most pain services, most established pain services, is what is called a pain management program, which is very multidisciplinary. So the psychologist will take a role in working with all the emotional issues and helping patients to communicate a bit better with their loved ones. And there will also be other professionals such as doctors, physiotherapists and occupational therapists, who also work alongside the psychologist to help somebody deal with emotional reactions. But what we're aiming for is that patients have a much more improved quality of life. So psychology does not promise to take away the pain. It's about learning ways of living with your pain, despite increased distress. So our aim is to help patients to be their own therapists so that you can improve your quality of life. Okay? Any questions at this point?
A question. It's actually a two-part question, but can pain be only psychological to individuals? Just kind of like unresolved issues that make them feel like they're in pain?
Well, pain is a physical problem, it's a medical issue. But what I'm trying to say is that it can have an impact on your emotional well-being. Unresolved issues might make your perception of pain appear to be much worse than it is, because if you're already depressed or you're trying to avoid some emotional issue in your life, and that pain might also, your perception of pain might be intensified. So for example, working in a service where people are experiencing a lot of pain in their, either in the buttocks or in the private area, that can have an impact on, that might bring back memories to do with past events like abuse, not in all cases, but in some cases. So it's a medical condition, but it can have an impact on your psychological well-being. Does that answer your question?
Yes.
Yeah. Okay, anyone else? No? Okay. Okay, well let's move on to diabetes. I told you I would take you on a whirlwind tour through a few different conditions. We can't cover everything tonight, so we've just selected a couple of topics. Okay, so most of you already probably know what diabetes is. It's a condition where a lot of people have high levels of sugar, and they're unable to metabolize the sugar with them because they lack the hormone insulin, which is produced by the pancreas. And there are two types of diabetes. Type 1, which seems to arise in young children and can affect anyone up until the age of 40, whereas type 2 is the opposite, associated with lifestyle changes. So on this one, so certain ethnic groups might be much more at risk of developing type 2 diabetes. It can also occur in people, ladies that are pregnant. They might have gestational diabetes. Okay, so I'll move on now to look at some of the psychosocial issues. Again, trying to highlight the role of psychology within diabetes. These are a couple of issues that might be problems for people living with diabetes overall. Those of you that know anything about diabetes, self-management is really important. So being able to monitor your blood sugar levels and making sure that your sugar levels do not drop to dangerous levels when you have what's called a hypoglycemic attack. And so as diabetes is a progressive disease, there is an increased risk of having complications such as poor eyesight, having nerve damage in your feet, or your hands, for example, being at much more increased risk of cardiovascular disease. But if you don't manage your diabetes well, your risk of having complications can be increased. Now with people like teenagers or maybe adults in general who maybe miss their insulin as well, of course their risk of complications is going to increase. There might be that fear of the future because now I've got diabetes, I'm not quite sure whether I'll develop complications or not. I'm not quite sure how to incorporate it into my worldview. There might be that fear of hypos because if you don't manage your diabetes well, of course you're going to be at risk of having lots of low blood sugar levels. And there might be that pressure to stay in control because what the medical team are concerned about is that people manage their diabetes well so they don't end up in hospital and they decrease their risk of getting complications. Loss is a huge issue because your pre-diabetes life, most people are able to do whatever they want, eat whenever they want, drink whatever they